Hello and welcome to my presentation on topical anti-inflammatory therapies. I will be mainly discussing the therapies used at Moorfields Eye Hospital. My name is Majid Fatui. I'm a specialist pharmacist at Moorfields, but I'm also a fourth year medical student at Barts and the London School of Medicine, and I'm also the current president of the Ophthalmology Society at my university. It's a great pleasure to present today as part of the educational e-health series for Eye Health Africa, and I thank you all for inviting me here today. And I can hope that you are able to learn something which is useful about topical anti-inflammatories during my talk today. So to start with a bit of background information, anti-inflammatories are used extensively in the treatment of ocular diseases. They can be broadly split into three different categories, which includes ocular steroid eye drops, non-steroidal anti-inflammatories, also known as NSAIDs, and anti-allergy eye drops, which I will touch upon today as well. Topical steroids, so eye drops, are the mainstay of treatment in mild and moderate forms of uveitis, but they are also used synergistically to complement systemic therapies, so tablets and injections in more severe presentations of uveitis. In terms of penetration via the topical routes, the absorbance of the drug is very low because of the many physical and anatomical barriers which are present, meaning only approximately 5% of the administered dose reaches the target cells, particularly at the back of the eye, so the anterior segment, which is where a lot of the uveitis diseases or subtypes of uveitis occur in. Despite this, they are very extensively used and very effective. So in terms of steroids, the indications for steroids are usually for short-term treatment. In order to treat the anterior segment of the eye, but can also be used after operations for post-operative inflammation. In terms of creams and ointments, we do use betamethasone or hydrocortisone, but these are mainly for atopic conditions involving the periocular skin. So the way that steroids work, the mechanism of action, they are potent anti-inflammatories, and they are also known as immunosuppressants. And the way they work in this is by mediating signal transduction on the glucocorticoid receptor. What this does is it inhibits the chemical mediators of inflammation, such as cytokines, and it also reduces the number and function of inflammatory cells, because these cells are activated by these signals. So if we're inhibiting these signals, we're able to reduce this effect. The growth glucocorticoid receptor, GR, is expressed in various amounts within the different ocular tissues. So because of this, we have variable therapeutic as well as unwanted side effects. So we can't always control the kind of side effect profile of the steroids, even though they are extensively used. So in terms of medications that we use, dexamethasone is our bread and butter at Moorfields. We use this extensively, especially for uveitis. It's particularly potent. It's one of the most potent ocular topical steroids available, and the strength is 0.1%. Prednisolone is a milder version, but it is still quite potent. The 1% particularly, but the 0.5% is also used for milder forms of uveitis. We use Topical, also known as hydrocortisone, which has a higher strength, which indicates that it's quite mild. It's a weaker steroid, but it is used. And this is similar to loteprednol, which is also a mild steroid. So these have lower potency. And then the lowest potency of steroids that we use is fluorometholone. And this is often for very mild forms of inflammation, sometimes on the surface only, whereas the eye drops with higher potency are particularly used when we need to reach the anterior segment of the eye and for more severe and extensive inflammation. I have here mentioned diphenhydramine, which is not used in the UK. We don't use that at Moorfields. It's extremely potent, and it's used mainly in America. But the reason I've touched upon this is to demonstrate the side effect profiles, which I will come on to in a moment. So the side effects that ocular steroids have, things that we need to worry about. Steroids are very effective medicines, but we do need to balance the effectiveness against the risks. So in this diagram, I will explain the kind of side effects which occur. The first one is in terms of what probably one of the most significant side effects is an increase in the risk of ocular hypertension and glaucoma. And this can be rapid or insidious. The glaucoma is secondary to the ocular hypertension, and we call this steroid-induced glaucoma. And the reason behind this is because of the steroids. They exert an effect where they deposit extracellular matrix within the trabecular meshwork. And this is what predisposes patients, especially if they're already at risk, to ocular hypertension. The next significant side effect is cataracts, which again, that's more at the posterior segment of the eye, so in the lens. And this is due to enhanced proliferation and differentiation of the cells of the lens, and is mainly due to exogenous glucocorticoids. So steroids that we use topically can, especially if used long term, cause cataracts. So it's a risk we need to balance against the benefits. Even more posterior, in the cornea of the eye, we can delay wound healing. So we need to be wary when we use these post-operatively if there is corneal involvement, which is often the case. But steroids are used because of their potent effects, but it's just again, a risk to consider. And finally, the fourth main significant risk is an increased susceptibility to infection. And what steroids have been implicated is a resurgence in various infectious eye diseases, such as herpes, and they can worsen or cause a resurgence, as mentioned, of these diseases. In terms of the ocular hypertension and glaucoma, I will mention the diphenhydramine eye drop as well, because this is sometimes known as glaucoma in a bottle. And the reason is because it's so notoriously known for causing an increase in ocular hypertension, even in patients who aren't always predisposed, that it often does cause steroid-induced glaucoma. This is one of the reasons we don't use it in this country. So yeah, very important to consider the many side effects of steroids, but they are very effective medicines. Further to consider regarding steroids, we need to be wary of our patients who are known as steroid responders. So these are patients that are high risk and they have a rapid rather than an insidious increase in their intraocular pressure. And this is whilst they're taking topical steroids. So again, we need to balance the risk of their intraocular pressure increasing and their risk of glaucoma against the benefit of treating their inflammation. Often these patients are higher risk of complications due to this, and it's really always a consultant-led decision of how to manage these on a tapering course of steroids. That brings me to mention that the way we use steroids at Moorfields and the way they should be used is as a tapered regimen. So this is similar to oral steroids, and topical steroids are tapered off if they're used for typically more than 5 days of treatment, or if it's given at a higher dose or frequency. And the reason we do this is to prevent the inflammation from flaring up again on withdrawing the medication suddenly, and also to maintain the anti-inflammatory action for a longer duration of time, for having a greater therapeutic benefit overall. So an example regimen can be demonstrated here: QDS for 7 days, 4 times a day, reduced down to 3 times after 7 days, twice a day for 7 days, and once a day for 7 days. And this sensible approach to steroid therapy will help to ensure you reduce the risk of side effects, and you also increase the likelihood for the therapy to work. Additionally, if you are using a tapered regimen, You should sometimes consider using a preservative-free preparation, and this is particularly relevant if your patient is taking high frequencies of steroid medications, for example, if it's hourly or 2 hourly, and it's for a long period of time. And this is because the preservatives in some of the eye drops can irritate the eye, particularly the ocular surface, and this can complicate things. So sometimes we do give preservative-free preparations, and you should consider this if you're using steroids for a long time. So yeah, as I said, steroids are the mainstay of treatment in uveitis, but we do use other anti-inflammatory groups. Non-steroidal anti-inflammatories aren't indicated in uveitis as such, but they are used for treatment of general post-operative inflammation in ocular surgery, and also because they work as quite potent topical analgesics. Ketorolac, which we use extensively, is really useful in controlling diabetic macular edema, which is really common after cataract surgery. So all of our patients after cataract surgery would routinely be, if they're diabetic, would routinely be administered ketorolac and maybe a day or two's worth of acetazolamide tablets to control their pressure. Diclofenac is also used, has a role to play in allergic inflammation, so allergic seasonal conjunctivitis. So the way these drugs work, they inhibit the synthesis and production of eicosanoids, and these include the prostaglandins, thromboxanes, and leukotrienes. And these are inflammatory cells which are responsible for the pain and the inflammation that occur after a trauma. And that's particularly if the surface of the eyes has trauma to it, such as in penetrating surgery, where you open the surface of the eye, such as a cataract replacement. And they're used for this reason because they prevent the inflammatory process in this way, as well as providing pain relief for our patient. So in terms of side effects, they're mainly local and transient, so you might get a bit of irritation and stinging. It has been reported in literature that you can experience rebound vasodilation, and if that's after prolonged use. So that's why typically the medications, topical anti-inflammatory NSAIDs, aren't used for longer than 4 weeks periods of time, unless indicated. So there's not many systemic side effects reported, but we still need to be aware of our high-risk groups of patients, which include pregnancy, as it is contraindicated in some circumstances, and asthmatics as well, particularly if they have had a history of asthma attacks and triggers due to non-steroidal anti-inflammatories. I have mentioned here flurbiprofen, which is tablets of non-steroidal anti-inflammatories. And this is something we do use at Moorfields, and the reason for this is because once it's systemically absorbed as a tablet, it actually has really good ocular penetrance. So it works very well as an anti-inflammatory and an analgesic for pain and swelling within the eye, even though it's taken as a tablet. So this is something we do use extensively as well. So a key interaction to be aware of, this is particularly between ketorolac and the eye drop or eye ointment Maxitrol, which contains dexamethasone, a steroid, as well as neomycin and polymyxin B, which are both antibiotics. And the risk here is that there has been incidences of corneal melt when these medications interact with each other. So to avoid this, we always advise to avoid co-prescribing ketorolac as well as Maxitrol together, and particularly if either of them have been used in the last 4 weeks, because Maxitrol tends to have quite a long duration of action. So we avoid co-prescribing these and using them together because of this risk. So just a quick touch about allergy eye drops. There are inflammatory causes behind allergic reactions within the eye, and this can lead to various forms of conjunctivitis. So allergic conjunctivitis, seasonal, perennial, and vernal conjunctivitis. And these are different manifestations of allergies within the eye. There's two groups of medications that we use to combat this. The mainstay is antihistamines, and these work by inhibiting the histamine-mediated inflammatory response, similar to how we would take an oral antihistamine like fexofenadine, but this is working within the eye to control the inflammatory process locally. Additionally, we do use mast cell stabilizers, and how these work is by stabilizing the mast cell membrane to prevent the granules from releasing the histamine, and this is done by preventing the priming with IgE and allergens, which is what causes the mast cells granules to release histamine. So these are more effective if they're used prophylactically to prevent histamine release and associated inflammation. And it's something that you have to use for a couple of weeks, minimum 3 to 4 weeks before you start having an effect. But yeah, they're mainly used for prophylaxis rather than treatment. So again, side effects are mainly transient. You may have experienced a bit of inflammation, irritation, and stinging. You can get dry eyes. It is worse with some eye drops, so it's always useful to co-prescribe or use lubricating eye drops in conjunction with allergy eye drops. Keratitis has been reported, as well as corneal infiltrates in long-term use as well. So in a few examples, we use antihistamine-wise, we use ketotifen, we use olopatadine, which is probably first line and most effective. It's used twice a day. And we use azolastine as well. And then in terms of mast cell stabilizers, here are a few examples: liloxamide, nedocromil, and sodium chromoglycate. But the main ones that we use are probably sodium chromoglycate, and it's one that you have to use very frequently, 4 times a day, at least for 4 weeks before it starts having an effect. So often we find our patients aren't very compliant with their treatment. So in terms of topical therapies, a few general considerations to think about. The surface of the eye, so the ocular surface, can only absorb 1 eye drop at each installation, and this is equivalent to 0.05 milliliters. So the dose of every eye drop, it doesn't matter which formulation of eye drop it is, if it's a steroid, any eye drop should always be 1 drop. And the patient needs to be advised to leave at least 5 to 15 minutes if they're using their eye drops together. And this is to allow sufficient absorption to occur. So there's some patients put a lot more than 1 drop, and it's just not going to, they are wasting it because the eye is not capable of absorbing any more than that at any time. You can still get systemic absorption from eye drops. It seems trivial, and the risk is known to be theoretical, but it has been reported in the past. And this is particularly relevant for treatment of uveitis, so steroids and NSAIDs. And this is due to the many contraindications of these medications, which still need to be considered. For example, if you're treating a child with long-term topical steroids, and they will be absorbing to some extent, and this can have impacts such as growth impairment. So it's always a risk to consider. And for example, NSAIDs, again, pregnancy and asthma, you have to ask these questions to make sure the risk is reduced. But another way to further reduce this risk is if you use a technique we teach our patients known as punctual occlusion. And this is where you press in the corner of the eye where you can feel a small ball. And this is the lacrimal punctum and canaliculum. And if you press there after you've administered the eye drop, this blocks the nasolacrimal drainage, so it's not entering the system through this route, which is how the eye drops enter the body. And it also has an added benefit of keeping the drug within the eye and allowing it to exert its effect more topically where it's needed.